It gives me enormous pleasure to be able to present some of our research on behalf of all the members of the Rheumatology Unit here at the Royal Adelaide Hospital. Many rheumatological diseases are caused by autoimmunity, and this is a process whereby the immune system inappropriately targets the tissues of our own bodies, and this can cause a range of conditions that we call loosely autoimmune connective tissue diseases. Most of them are characterised by the production of what we call autoantibodies. They're antibodies mostly directed to the nuclei of cells, and you can see these little cells with nuclei all lighting up. These are anti-nuclear antibodies, and they're present in most connective tissue diseases. Now, these diseases are mostly diagnosed on the basis of their clinical features, so I'm going to show you some of them now. You may have heard of lupus and Sjogren's syndrome, inflammatory muscle diseases. There's even one called mixed connective tissue disease, which has features of a number of the other ones. And tonight I'm going to focus on two of them, rheumatoid arthritis and scleroderma. And you can see that each of them has additional antibodies which are really a little bit more characteristic of those diseases. So combined with their clinical features, we usually arrive at the diagnosis. So turning to rheumatoid arthritis, the most typical feature clinically of this disease is inflammation in the joints. That can really be almost any joint of the body, and these joints become painful, swollen and stiff, and if they're left untreated, this inflammation eventually can lead to joint damage that we call erosion. So on x-rays we can see these as little holes in the joint. And this is what we want to prevent when we're treating the disease. So we want to take us back to a normal looking joint. What I'd like to say though, that the outcome for patients with rheumatoid arthritis these days is much more optimistic. So instead of developing changes like this, we expect people to look like this. And it's fair to say that most of the advances in rheumatoid arthritis have actually come about because of better ways of using medications, as well as some newer medications that have arrived on the scene in recent times. Now, the very first question that comes to mind when most people are given a diagnosis of rheumatoid arthritis for the first time is, why did I get this disease? And it's fair to say that we do know quite a bit more about how environmental factors such as smoking and various infections might combine in somebody who's already genetically predisposed to this disease. They may have a family member with rheumatoid or some other autoimmune condition, to lead to changes within the mucosal surfaces. So these are other sites within the body like the lungs of smokers, the periodontal tissues in people, the gums of people who have periodontal disease. And now increasingly we're thinking that maybe the mucosal lining of the gut, where we see the microbiome, may have an important role in driving these inflammatory changes and autoimmunity. And these changes lead to the production of autoantibodies. And in the case of rheumatoid arthritis, these are called ACPA. And then eventually these move on to the joint and we get joint inflammation. But we still have a lot to learn before we have a cure in this disease. But we have learnt much more about how to use the medications, the drugs that we call disease-modifying anti-rheumatic drugs, or DMARDs, much more effectively to control the rheumatoid arthritis and before the joint damage occurs. We are aiming now for remission. That is, the disease is as good as gone, but they are on medication, so it's not really a cure. And we can measure this using a number of tools. For example, the disease activity score, the DAS28 score, which is a combination of numbers of joint counts, both swollen and tender, some blood tests, and some questionnaires, and that's shown on the left-hand side there, and that gives us a number. The secret to success, though, has been to use the medications early, and usually in combination, so more than one. And almost always we use this medication called methotrexate. Worldwide, this is still the standard of care for brand new rheumatoid arthritis, unless somebody has some medical reason why they're unable to take it. So we've learned how to use this more effectively and to minimise any side effects. And we've also learnt that we can use this DAS28 score to help us be guided in adjusting and adding new medications until we reach a state that we've predetermined as being low disease activity. And this gives us the best chance of preventing any further joint damage. And indeed, in the last decade or two, we've done exactly this in our clinic here at the Royal Adelaide Hospital, and our outcomes look nothing like the picture I showed you before. You can't even tell anyone has rheumatoid when you come to the clinic just walking around, with minimal use of some of these other more toxic drugs like non-steroidal anti-inflammatory drugs, corticosteroid drugs like prednisolone, and at least 40% of patients are in a very stringent form of remission by year 1. And it's fair to say we've achieved this well before the big blockbuster biologic DMARDs became more widely available. So how have people learnt around the world about how to improve the care of rheumatoid arthritis? We can do randomised controlled trials of new drugs, of course, and that's very important. But actually we learn a lot from the people who come to our clinics. So we have developed what we call longitudinal observational cohorts. And in the late 90s, Professor Clearland, under his guidance, we developed a longitudinal observational cohort of rheumatoid arthritis here at the Royal Adelaide Hospital. So people coming to us for the very first time with their rheumatoid arthritis were invited to join our cohort, which meant that they gave permission to us to collect clinical information about their disease, collect biospecimens like blood and DNA. We asked about their perspective of their disease through questionnaires called patient-reported outcome measures. And then we extended this to other autoimmune diseases in the clinic. So we have a cohort of scleroderma, a cohort of myositis, and actually a different rheumatological disease now we're developing, gout. We'll give you a talk about that one other day. And this has given us a valuable platform to do research. So that's allowed us to define outcome measures, clinical features, and genetic predispositions to predict what's going to happen. That may include even pharmacological models of how people handle the medications that they take. And we've even been able to link this data that we've collected to government databases to help us really understand the costs and burdens of these diseases. And we've even been able to embed clinical trials within our clinics. So one of the most important rheumatology interests or research interests that we've had in the rheumatology unit, we've heard about already, has been the role of fish oil as an anti-inflammatory in rheumatoid arthritis and other diseases. So we know that the non-steroidal anti-inflammatory drugs like Nurofen and so on, they work by blocking an enzyme called cyclooxygenase, and so they can then reduce the inflammation, redness and swelling, and the symptoms are relieved. But they come at a cost. They have a pro-clotting effect and they increase the risk of heart attacks and strokes. So generally we don't like recommending those as long-term therapy anymore. Now, fish oil contains omega-3 fatty acids, EPA and DHA are two of these. You'll see them on the slide there. And they work by competitively inhibiting the cyclooxygenase enzyme. So when they are metabolized, then they produce different molecules which are actually anti-inflammatory and anti-clotting. So they control the symptoms, but they are much safer than non-steroidal anti-inflammatory drugs. This little cartoon here, really, I don't expect you to see the details, but just demonstrates that we go through multiple steps to bring the disease under control, changing the medications. We usually start with the 3 listed at the top there, and once we've reached the disease state that we desire, we can stop. But sometimes the disease is still active, and we have to add a 4th drug, leflunomide. And on this background, we undertook to do a randomised controlled trial of a high anti-inflammatory dose of fish oil using oil in the bottle. We compared it with a control oil that had just a little bit of fish oil in it, so it smelt and tastes like fish oil, so that the patients didn't know which one they were getting. And we had a look to see which fish oil was more effective, if any. And we used the fact that we moved on to leflunomide as, I guess, a way of saying the triple therapy, the 3 medications, was insufficient. It had failed. And you can see that those people who were taking the high-dose fish oil in green were less likely to need to add another medication. So we were able to say that people on fish oil did not need as many DMARDs as people who were not taking fish oil. And more than that, they were twice as likely to go into remission than the people who weren't taking fish oil. And that is our goal of therapy. So on that basis, advice to take an anti-inflammatory dose of fish oil, which is about a tablespoon of the oil out of the bottle on a little bit of juice, usually before dinner time, not at breakfast, on your breakfast cereal, You'll just have fishy tastes and coffee all day. We advise them to do that indefinitely. And not everybody can, but the vast majority of people can if they're advised how to take it properly. And of course, if you can't tolerate the oil, you can get more concentrated versions so the volume is smaller, or even have it encapsulated with a smaller number of tablets if it's more concentrated. We've since gone on and looked at other factors that might be modifiable, sort of lifestyle factors, things that people can do for themselves. So firstly, we have now able to measure the amount of EPA that's in the patient's plasma or in their blood. That tells us really how much fish oil they're getting into their system. And we were able to demonstrate that if you had an increase in your plasma EPA, you were much more likely to have a low disease state or remission. So that was more or less what we knew, and we've now found another way to measure it. And then we looked at two other modifiable lifestyle risk factors, smoking and obesity. We know smoking is a risk factor for getting the disease, and it is also associated with a poor response to therapy. On this graph here, you can see we have the y-axis, and as you move up to the top, that means that you have an increased chance of having really good disease control. And on the x-axis here, moving from left to right, we have the BMI with increasing BMI, meaning increasing obesity as you move from left to right. Now you can see that the people who have never smoked have the flat blue line. So they have a pretty good likelihood of having very good disease control, irrespective of how much they weigh. But in people who smoke or who have ever smoked, whilst they have a reasonable chance when they're of normal body weight, as their body weights increase, their chance of having good disease control drops dramatically. So this is really the first time that we've demonstrated this relationship between weight and smoking, and really underscores the importance of helping people with rheumatoid arthritis to target these two risk factors to improve their outcome. Just a little bit of a change of gear here. We're now going to talk about scleroderma. Now, we thought rheumatoid was challenging. This is complex multi-organ disease, poses many challenges for people with the disease, as well as the healthcare providers and the researchers looking at this disease. It's characterised by three sort of pillars, if you like, of pathology. Firstly, inflammation, which reflects the autoantibodies I was talking about before, and maybe things like joint and muscle inflammation. Vasculopathy, which is sort of narrowing of blood vessels. For example, you can see the white fingers there. We call that Raynaud's phenomenon. And so this is a loss of circulation due to constriction of blood vessels induced by the cold. And there are lots of other vascular disease manifestations listed there as well. And then interstitial fibrosis, which is like a scarring phenomenon where you have increased deposition of collagen, most typically in the skin. So you get this very thickened skin, maybe just in the fingers, but even more proximally as well. But this process also occurs in the other tissues of the body as well. So you can have involvement of multiple other organs like kidneys, lungs, hearts, and gut. Now, in 2006, when I was chair of the Australian Scleroderma Interest Group, we established this observational cohort like I referred to earlier. This time it was Australia-wide in patients with scleroderma. And we've now got about 2,000 patients, which represents about a third of the people in Australia with scleroderma. And we likewise collect comprehensive clinical data and medication use, and the biospecimens which are kept at the University of South Australia, just 2 doors down. And we learnt quite a lot about the disease burden. Amongst all the autoimmune rheumatic diseases, scleroderma has the highest burden of disease. It has the lowest quality of life, both in the physical and mental scores. So these are the two lines down on the right-hand corner there, with the physical score at the top and the mental score at the bottom. And scleroderma is right there on the left-hand side, worse than many other chronic diseases like heart disease, lung disease, and depression. It has the highest mortality with a reduced life expectancy, and generally heart and lung complications these days are the most common cause of death in patients with scleroderma. And that was one of the things that we focused on, particularly in our cohort study. We also know this is really probably one of the most expensive autoimmune diseases, despite the relatively small numbers of people, with just around about $60 million a year spent, averaged across all the patients with scleroderma on the direct health costs. So that includes hospital admissions, outpatients, allied health, and so on. And then the indirect costs, which are things like unemployment, loss of productivity, is another 40 million. So together, $100 million a year in Australia on this disease alone. The strongest driver of costs is one of the heart-lung complications, pulmonary arterial hypertension. Now, this is a kind of high blood pressure, if you like, but it's in the blood vessels within the lungs. And this happens when the pulmonary arteries, which take the blood to the lungs, become thickened and the blood flow is reduced, and the heart has to work harder to pump the blood through the lung circulation. And that means that you can't get the oxygen that you need to the rest of the body. And as a result, you grow very tired when you're trying to climb stairs or do housework or develop other symptoms like shortness of breath and chest pain. So as rheumatologists who see most of these patients with scleroderma, when they say, I can't do the things that I used to do, we need to think, could they possibly have pulmonary arterial hypertension? And the chance of this happening is about 1 in 10, so 90% of people don't even get this problem. But we do have responsibility, really, to try and identify this early in the 10% of people who do develop this problem, because we know early treatment can improve outcomes. And in fact, we developed a screening program in this cohort study around Australia, and we've demonstrated that this saves lives. So the people who were identified with this complication through the screening process have nearly a 100% 3-year survival, which is not quite as good as the ones who were identified once they'd become truly symptomatic. We usually use an echocardiogram to try and work out who should have the definitive test, which is called a right heart catheter. But it has some problems with it. It doesn't always help us measure the pressures. It takes some time and some real expertise. People living in the country regions can't access it. And it is quite costly to do this in every scleroderma patient every year. So we've looked at developing a new algorithm for screening for this complication. It's just dependent on lung function tests and a blood test, a biomarker that we call NT-proBNP. So we can do some pulmonary function tests, lung function tests, which give us numbers that can make us suspicious that this person's at risk. We can do a blood test. The beauty of this, though, is that if both of those tests are negative, we know the chance of them having pulmonary arterial hypertension is very low, and we need do no more than redo it all again in 12 months' time. But if either of those tests is positive, then we send them off to the cardiologist to say, what do you think? Maybe a right heart catheter would be a good thing to do on this occasion, and any other tests that are indicated. So this is not currently funded, this biomarker on the MBS system for this indication. So we're actually going to government now to mount a campaign to have this listed for reimbursement for this purpose, based on the fact it's easy, it's accurate and reliable, it's as good as some of the other more complicated algorithms that are out there, and it, of course, is much less expensive. And in fact, one of our studies is to, with one of our PhD students, is to do this, implement this screening program in southeast Queensland, where they have a particular difficulty in getting good screening for this condition. And I just want to show you now just a walkthrough of just some of the studies that we've been doing with our scleroderma cohort study, just to show you the sort of things that we can do. So one of them is to look at the benefits or otherwise of blood thinners in pulmonary arterial hypertension. This has been quite contentious. People still don't really know the answer. So we've had a collaboration around the country to look at that. I've collaborated with a number of collaborators through ASIG, and I have a wonderful group of colleagues in Victoria who work on much of this work with me. So we've looked at pulmonary arterial hypertension, we've looked at lung disease with researchers in New South Wales, digital ulcers ourselves, some of the other really more complicated autoantibodies with researchers here in Adelaide. We've done some quite sophisticated genetic studies to predict disease, both nationally and internationally, actually. And we have some other collaborations here in Adelaide as well, looking at muscle disease and looking at heart disease here at SAMRI. And there have been a range of international collaborations as well, looking at funny things like calcinosis, how we measure this disease in terms of the damage, more antibody work, the gut, which is a real problem in this disease, and really working out how active it is. We've not been able to develop one of these DAS-type scores. It's very difficult to score. And we're also now moving into the online space to help patients manage their disease using online resources with the Canadian collaborators. And this rare but quite serious complication that can affect the kidneys as well. I also want to just briefly say how important the engagement of the patient, the health consumer, or just the person who has the disease, I never quite know how to talk about that, in really helping us understand these diseases, because I think we've really underestimated the impact of these diseases to the individual and to the health services in terms of cost. And increasingly now we're involving consumers at every level of deciding what we should be researching, how we're going to plan and implement that research, how we're going to measure it, and some of the consumer organisations who advocate for people with arthritis and so on at the government level, like Arthritis Australia. So what does the work we've been doing mean for people with scleroderma? So we've developed these centres of excellence, if you like, around Australia, and that's how we deliver our care. So they give us the capacity to have multidisciplinary teams and our scleroderma nurses in the room. We've been able to standardise the care, and we've now been able to attract industry-sponsored trials of new therapies. So Australians with scleroderma can now have the first chance at new therapies for this disease. And in fact, we embed research at really every level of our clinical service with the aim for continuous improvements. So with that, I'll just show you some long lists of all the people who've contributed to this sort of work. So with the rheumatoid arthritis work here at the Royal Adelaide and the Queen Elizabeth, and these have been financial sponsors. And you can see the ASIG work for scleroderma is massive across the country, with lots of support from industry and from other consumer organisations. So thank you for listening.
Thanks very much, Susanna. That was a tour de force on what's going on in rheumatology. We're only a fraction of it, I'm sure. What we're going to do now is I'll just have a bit of a chat with Susanna about some of the questions that come to mind. We've had some questions submitted by the audience beforehand. In fact, a lot of questions which we won't get through all of them, but I will present some of these to Susanna, and then after we've finished the filming component, we'll have an open session with the audience. So I'll just move ahead. One of the things that struck me as you were talking about the early arthritis clinics and the need to get onto the disease quickly. All of us get aches and pains when we do things, and gardening and whatever. What should make a person who's getting some joint aches and pains think that this is more than just simple wear and tear, and where do you go from there? Because otherwise you'd be flooded with these people.
That's true, and in fact our goal is to try and see people as quickly as we can in our clinic. So we have a fast-track referral service so we can triage patients as quickly as possible, and we encourage GPs to call us up actually, because it's not easy when you read the referral and this patient's got pain. Well, is this something they've had for a long period of time, or is it something new? And I think it's when there's a clear change from what's normal for you. And one of the most typical features of rheumatoid arthritis actually is the involvement of the small joints. So when the hands become stiff and sore, the balls of the feet first thing in the morning when you get out of bed, that's unlikely to be just brand new osteoarthritis out of the blue, which is, I guess, the wear and tear that you're talking about. Although that can be an inflammatory arthritis in its own right, that tends to come on much, much, much more gradually. The other major feature that really suggests there's something serious going on is when a joint suddenly swells up and seems to be full of fluid. So, you know, a joint that's very swollen and tight, like a knee, or if all the fingers suddenly look very puffy over a matter of weeks, that would be considered a real problem. And when the doctor does some blood tests, they might find that the inflammation in the blood is increased. So if any of those things happen, then we encourage GPs to ring us up. Don't even write the letter. Call us up and we go from there.
Okay, thank you. The fish oil obviously has been very successful. When you go to the chemist, there's a host of different oils, krill oils and other things, which can be confusing, I'm sure, for the consumer out there. Can you make a little bit of sense of that for us? I mean, does it really matter which one you choose?
Well, in the first instance, it probably really needs to be a fish oil, because what we're really after are the omega-3 fatty acids. So these are these long-chain fatty acids, the EPA, DHA, and they are mostly in the deep sea fish. They are at the top of the food chain. So they eat the krill and eaten by other smaller fish, and they eat the smaller fish, and you get a concentration of these good oils, if you like, in these deep sea fish, and it's from those, or farmed versions of those, that these fish oils are created. So unfortunately the krill doesn't really have sufficient omega-3 to have the effect that's needed, because really it's all about the dose, and you need perhaps 2.7 grams a day, thereabouts. That's the magic number we've settled on, that is not exactly the same as what's written on the bottle either, because that gives you the number of milligrams of the oil, and you have to look a bit more closely as to how many milligrams of the omega-3 fats. So that's the EPA plus the DHA added together. So if you have a standard oil, given that 1 ml goes into one little capsule and you need a tablespoon, which is 15 mils, to get that 2.7, you need to look on the bottle and say, oh, that means I need 15. Well, that's why we recommend the oil in the bottle, because a tablespoon on a little bit of juice is a lot easier to get down in one gulp than 15 capsules. Or you try and concentrate it further, and then that's only a teaspoon or maybe 5 or 6 capsules.
Is there anybody who should not be on fish oil? I mean, you mentioned a slight blood thinning effect. If someone's already on blood thinners because they've had a blood clot or something, does that mean they should not be on fish oil, or is it not really that important?
This comes up all the time, even amongst our own colleagues who want to operate on people who've been on fish oil. And I think if you are an Eskimo and you've been eating mammals who eat deep sea fish and eat deep sea fish, you have enormously high levels of EPA, and yes, they have many more bleeding problems, strokes and things like that. But on the background of a normal Western diet, which is filled with the omega-6 fats, which are the bad fats, if you like. Most of us are dripping with omega-6 from our normal diets. The relative concentration of omega-3 is actually not that high. So the impact on our platelet function is actually probably almost non-existent. And I remember that Les was involved in some bleeding time studies which showed there was no change. And I guess the very fact that even though our surgeons say, oh, you've got to stop the fish oil before we do that operation, and it takes 3 months for the fish oil to get out of your system, and we don't see massive hemorrhage, would suggest that it's actually not really a problem. Okay. Should you have anticoagulants, for other reasons and fish oil? I think it really depends on what risk you have for bleeding. So if you have some gut problem that's likely to bleed, then you might think twice.
And is the fish oil good for anything else apart from rheumatoid arthritis? And I guess we mentioned osteoarthritis, but couldn't help but wondering, you're talking about scleroderma. Is fish oil good for scleroderma?
Well, it's a very good question, because of course what we're really looking for in scleroderma is a vasodilator, something that opens up the blood vessels. And that effect of the fish oil changes the prostacyclins that are produced, prostacyclins which are vasodilatory. So we've never actually done the studies, but I've often wanted to do that. But there are other studies in other conditions that demonstrate benefit. Things like lupus, psoriasis, not so much in the way of osteoarthritis. There was a study done with Les and our other colleagues at the Queen Elizabeth on fish oil in osteoarthritis, and unfortunately that didn't seem to show the same benefit. There are lots of other things in joints which cause pain, unfortunately, as well as inflammation, changes to the cartilage and the bone and so on, and there wasn't a good response there. There's some evidence that there are other collateral health benefits as well in terms of improving your cardiovascular risk. And given that that really now is probably the main issue for people with rheumatoid arthritis, we really push good control of cardiovascular risk factors to reduce heart disease. There may be some additional benefits in having fish oil that can improve your lipid profile a bit, reduce your blood pressure a bit, things like that.
With and a lot of the questions are about autoimmune disease, but with regard to the scleroderma, clearly from what you've said, it sounds like it's been a much bigger challenge perhaps than the rheumatoid arthritis. And it sounds like you haven't had quite the same level of success in the early clinics and the induction of remissions. Why is that?
It's a very... the disease is very varied. So you have people who have very limited disease in terms of their skin involvement, who have nuisance problems, but nothing generally that is all that serious, although they can get this pulmonary arterial hypertension I mentioned before. About a third of the people have this diffuse form, which is much more severe, affecting the skin thickening all over their bodies, and they develop a lot of other sort of fundamental problems. We have a reasonable idea of what drives some of these changes, but we don't really have a disease-modifying therapy, whereas we now know so much more about in rheumatoid arthritis. There's this inflammatory molecule or that inflammatory cell, and we have treatments that target them beautifully and we can stop their function. But we've not really found the same treatments. It's also difficult to prove that they work as well because it's really hard to measure what's an improvement in someone whose problem is mostly in the gut or mostly in the skin. They're completely different.
Yeah. Well, one of the questions sort of relates to that in that it was asked, somebody said they have 4 autoimmune diseases and wondered whether these treatments for antibodies are always specific for this particular diseases, or is there a single treatment that's going to fix the lot?
Well, I guess one of the beauties of being a rheumatologist was that certainly when I first started, we had a limited array of options and they seemed to work for most things. So that was handy, but we are now trying to be much more scientific about it and we now understand much better about what drugs work better in other things. And in scleroderma, we mostly use therapies that target whatever the major problem is. So if it's a reflux problem, then we'll use an anti-reflux medication. If it's the Raynaud's phenomenon, we'll use tablets to open up the circulation and so on. But we're now moving into other types of therapies which have anti-fibrotic effects. We're doing a couple of trials with industry of cannabinoid type receptors. There's some evidence they have an anti-fibrotic effect. Even things like autologous stem cell transplants are now becoming in vogue for people with very, very severe disease.
Right. And one of the questions relates, I guess, to genetics. The question was about a twin with celiac disease, but I guess it gets down to, what is the genetic associations? And if you have a relative or a close relative with an autoimmune disease, are you at an increased risk of getting the same thing?
You're probably at increased risk of getting an autoimmune disease. More than likely, it's actually going to be a different one. Sometimes you'll see the same diseases in the same families, but quite often you'll see sort of clusters of different kinds within the one family. And that's because there are probably thousands of genes that drive autoimmunity, and you're going to inherit them in different combinations from your 2 parents, and your combination might give you autoimmune thyroid disease, and that person's combination might give them scleroderma or rheumatoid arthritis. So definitely it's probably an additive effect. We haven't really learnt quite how to measure that, and probably in most of the diseases that risk from genes is about 30%, I would say, and the rest of it comes from the environment. So now we know in rheumatoid that's things like smoking and obesity and bad gum disease. We don't know so much in scleroderma. If you work in a silica mine or with old-fashioned dry cleaning fluids, maybe, but there aren't many people with scleroderma who have that history.
And I guess it relates in a way, the disparity between men and women with autoimmune diseases. Is there a difference, and if so, why do you think that is?
It's been one of the key features of autoimmune diseases that we've known for a very long time, which they're mostly more common in women. That's not always the case, but it does suggest that there's an influence of hormones in some way. And in fact, many people who develop these diseases develop them while they still premenopausal, although it can occur later in life. Having said that, the men with scleroderma sometimes suffer worse fate sometimes than the women.
And in regard to the obesity, is it just because carrying that weight around just makes things more subject to stress, or is it the fact that there's the so-called metabolic syndrome where you have the fat actually promoting inflammation? What's the story there?
We think that probably it's a fatty, inflamed organ. That there is the production of various inflammatory mediators by the excess adipose tissue that makes up fat.
Right. And there was one particular question here about Plaquenil affecting the eyes, and I guess it comes into that early treatment algorithm that you have. I mean, the methotrexate, the Plaquenil and so forth. What are the major concerns, and how often do you have to stop those because of side effects such as perhaps effects on the eyes?
Yeah, so that was the hydroxychloroquine in that little list there, but Plaquenil is the trade name. It's an old-fashioned anti-malarial. It doesn't work very well for malaria actually, but we use it a lot in lupus and still in rheumatoid arthritis in combination with the other drugs, because it's not the most effective therapy, but it certainly has a role. There is an increased risk after maybe decades of use, 10, 15, even more, of the drug itself depositing at the back of the eye, and that can be irreversible and cause damage to the vision. It's very uncommon to the point where we have to actually stop the drug, but we have really taken the stance of making sure that everybody who's on that medication has their eyes checked on a regular basis, because the ophthalmologist can see very easy early changes before there's any change in the vision. But that's not to say that it isn't a very valuable drug, particularly in lupus. Even in people with really quite nasty lupus with lots of other strong drugs and so on, it really has an important role in really stabilising the disease so you don't get these flares of disease. So mostly people generally take it for a long period of time, and really we have to stop it. Maybe if they have other eye problems like macular degeneration, and we might just play it safe and stop it.
And I guess another drug that has been in common use historically are steroids or prednisolone, which has obviously got some problems. Where would you see the role of prednisolone or steroids in all of this now? So
prednisolone is still the best and fastest acting anti-inflammatory that we have since 1945 or whenever it was first discovered. So when people have very severe joint inflammation, it can be a lifesaver, and certainly if they have a life-threatening or organ-threatening complication of some of the other bizarre things that we look after in rheumatology, we use quite a lot of prednisolone, cortisone, we use the terms somewhat interchangeably. But we do know that they come at a cost if you use them for a long period of time and in high doses. So in rheumatoid arthritis, we generally try and avoid using the oral tablets. It's very easy to have a little bottle of those in your bathroom cupboard and you say, I'm having a bit of a rough day, and take a few more, and then nobody really quite knows whether we're controlling the disease with the medications that we want to use. So we usually use them by injection. So when a knee or other joint is very inflamed and swollen, taking the fluid out and putting methylprednisolone into them is a very effective way of controlling that inflammation and the damage, and you get some generalised benefit that can last for up to 2 months. And if there aren't any joints like that, we'll often just inject it in, like a tetanus injection into the thigh, and give them relief that way.
Okay. Well, so just perhaps in my final question might be, where do you see the future of all the development? And you've touched on it to some extent with all of the things that you've covered. Do you think there will be more monoclonal antibodies, more small molecules? Where is all of this going, do you think?
There's an extremely busy, long pipeline of things coming through for rheumatoid arthritis and some of the other inflammatory joint diseases like ankylosing spondylitis and psoriatic arthritis. So we're really seeing major changes combined with these sort of doing the best we can with some of the less expensive medications before moving on to these more expensive so-called biologic therapies. But there are many more things coming through in those pipelines. What we're really looking for is the diseases where we struggle, so scleroderma, lupus. But I think if I look back 10 years ago, we rarely got offered a clinical trial of a drug for scleroderma. And now we get them several a year, to the point where we're going to have to start saying, sorry, we haven't got enough patients for you anymore. So I'm much more confident that we will see these similar sorts of biologic therapies in these slightly more difficult diseases to treat.
Thank you very much. Well, this concludes our formal question and answer session. Thanks very much.